Assalamu alaikum and good evening. This is the fifth presentation as a pre-course lecture. And in this presentation, we're going to discuss an important region that is really the heart of endoscopic endonasal approach, where most of the pathology going to be located and going to be attacked, which is the sella and the parasellar area. The sella parasellar area is the area that located between the two middle foci, as we discussed in the first presentation. We'll start with the anterior coronoid, which is a projection of the sphenoid ridge or lesser wing of the sphenoid, lesser wing of the sphenoid bone, and has two attachments. One is the anterior root, and the other one is the posterior root. The anterior root connect the anterior conoid to the planum sphenoidale, as you can see here, and the posterior root, which is the optic strut. And important anatomical orientation that the optic canal is actually oriented 35 to 45 degree laterally, so you cannot see it well when you look at the bone from the top. So if you tilt the sphenoid bone as it's seen here, you'll be able to appreciate the optic canal. The area that communicate or connect the anterior root of the anterior conoid is called the limbus, and this limbus is attached to the planum sphenoidale through the jugum, which is an elevation in the planum sphenoidale in the posterior part of it. And what's going to communicate the two posterior root of the anterior conoid, which is the optic strut, is the tuberculum sella, which is a thick bone and elevation just anterior to the sella thoracica, and between the two optic nerve and the canal, you can appreciate a depression, and that's separating the limbus from the tuberculum sella, which is the prechiasmatic sulcus or chiasmatic sulcus. The pituitary fossa is located just behind the tuberculum sella and anterior to the posterior structure of the sella parasellar area, which is the dorsum sella. As you can see here, the posterior colonoid, which is a little different from the anterior colonoid, that is irregular in shape, and they are not mirror image. They can have different size and the shapes, and they're communicating again are connected to the dorsum sella, which is the upper part of the clivus. The carotid sulcus is located just lateral to anterior part of the pituitary fossa, and it's located actually inside the cavernous sinus. So the cavernous sinus is going to be here, and you're going to have the proximal and distal ring to separate this part of the carotid from the intradural part. But notice also it's sandwiched between the anterior conoid and the middle conoid, which very rarely these two clonoids can be attached to fibrotic tissue. So when you remove the anterior colonoid, you need to be careful about not to injure the internal carotid artery if there is a fibrous tissue connecting the anterior colonoid to the middle colonoid. And this is the internal carotid artery going to cover the foramen lacerum and going to go inside the internal carotid canal in the petrous bone. This is a roton picture where you can appreciate it again, the anterior conoid artery that cover with the dura, and then the dura continue over the optic nerve through falciform ligament, and you can appreciate an elevation in the planum sphenoidale, which is the jugum. Posterior to that is the limbus, and then prechiasmatic sulcus tuberculum can be seen after that, and then finally you're going to go to the pituitary fossa. Notice the internal carotid arteries just lateral to the optic nerve and make the two optic nerves kiss, which will make the chiasm, and posterior to the chiasm is the optic tract, and in between is the lamina terminalis. This is important anatomy. In dry bone, you can appreciate the foramen lacerum, where the internal carotid artery going to be covering and lie on, and then the internal carotid artery canal inside the petrous, where the internal carotid artery going to enter the cranium in this location. Foramen ovale just lateral to that, and the splenozium we discussed before. Posteriorly here between the clivus or the dorsum sella and the petrous apex, there is a groove which is petroclival groove, and that groove is where the sixth nerve going to come through from the posterior fossa to the middle fossa parasellar area, and then enter the cavernous sinus and to the orbit through the superior orbital fissure. Now this is the petroclival groove, where you can appreciate the sixth nerve, but now it's a foramen and the canal that is made of the lateral border of the dorsum sella, petrous apex, and now you have a ligament which is petrous sphenoid ligament or Grober ligaments, and now it's called, and we're going to call it Dolores Canal. Notice this area is very rich and venous structure, which is communicating the cavernous sinus to the superior and inferior petrosal sinuses. It's called the Gulf. And when you reach there, you can have a bleeding before you injure the sixth nerve. I want to show this to appreciate the sphenoid sinuses not always well pneumatized. There are four type and subtype of the sphenoid sinuses, and here we made a coronal cut where you can appreciate the sphenoid sinus and the cavernous sinus, and the left side, the petrous bone in the back, and you can see the pituitary gland and the pituitary fossa, and two optic nerve and the other nerve, 6 for third and fifth nerve. Now we're going to flip the coin and see the same area from the nose or nasal part. You can appreciate here laterally is the optico carotid recess, and the optic carotid recess is actually a pneumatization of the posterior root of the anterior clonoid, which is the optic strut. And you can appreciate it here in the middle. You can see the sella face, and laterally you can appreciate the optic canal and optic nerve. Inferior lateral you can appreciate the ICA, internal carotid artery, and between is the optic strut, where here it's called the lateral OCR or opticocarotid recess. And inferior to the sella is the clivus and sphenoclival recess can be seen. Now we're going to drill the face of the sella and remove the bone, and that going to show the dura of the sella, and just anterior to that is the tuberculum, and then prechiasmatic sulcus, and the limbus, and anterior to that is a thick bone again, that is the jogum, which is the posterior part of the planum sphenoidale. And very anteriorly you can start to appreciate the posterior the canal to the posterior ethmoidal artery. And here I'm showing two donated lines just medial to the lateral OCR at the side of the internal carotid artery, which reflecting the proximal and distal ring of the internal carotid artery, which is basically will make the cave of the internal carotid artery intradural. And this is the cavernous sinus here, going to be located at this lateral to the sella, uh, this proximal to the proximal ring, of course, and going to communicate laterally, inferiorly to the superior orbital fissure. As you can see here, we're going to put two picture. This is the two faces of the sella parasellar area with all structures. Thank you very much.